Trey does not require any introduction. I'm sure you know him, and he's a consulting cardiologist, and very well known, well respected, the teacher. No doubt many by teaching. And Dr. Che also played a major role in organizing, inviting speakers to make these acute medicine Zoom teachings, which I hope will be very helpful to you all. Many of the feedback suggested they has been helpful to many of you, and no doubt this afternoon too. And as Dr. Choi mentioned in his email, please engage, correct? My testing, not examining. This is simply the best way to learn. When you commit yourself, you just learn better. So, welcome. Thank you very much, Dr. Choi, and I'll pass the time to you. Look forward to your talk.
Thank you, Dr. Singh, for your kind introductions. So today I'm going to share with you 10 or more cases that I encountered actually in the past 10 years or so. So I make it into a PowerPoint and share with you. And I hope there's someone here to answer my questions in the Zoom. So this is my first case. So may I ask anyone here would like to answer the questions in the first case? Can you open your microphone and answer any response from anyone? So I don't want to check the chat box while doing the presentation. So can anyone? You don't need to open the video, but I need you to talk, just like examination, because in examination you will be given an ECG, and then you will be asked about the diagnosis and management. I want every one of you to have a taste of what examination is going to look like. So would anyone may just there's no penalty at all. So just speak up, and nowadays doctor need to speak up, and in order to learn, there's no point of sitting passively listening to the talk. So anyone?
Can you hear me, please?
Yes, excellent. Thank you very much. You are the first brave guy to answer my question. So this is the ECG station in a short case examination. So this case is a 46-year-old chronic smoker. He presented with sudden onset of severe chest pain for 6 hours, and associated with shortness of breath and nausea, sweating. And the blood pressure is 100/70. Pulse is 110. There's no significant difference in blood pressure in both arms. Patient is clinically in distress, but not in heart failure. There's no murmur, no radio or radiofemoral delay. So this is the EKG of that patient. So what is your findings?
The photo shows an ECG of the patient taken 29th of August. The pulse rate is approximately 100 beats per minute. It's a sinus. One striking abnormality noted would be a gross ST elevation noted over the lead V2, V3, and V4. And they are also, this would suggest a case of acute myocardial infarction, ST elevated myocardial infarction of the anterolateral heart.
Excellent. So first of all, very good answers. So in examination, so you have to mention this is the EKG or ECG of this patient taken on the date of August 29, and it's a sinus tachycardia, right? Because it's sinus, every P wave is followed by QRS. The heart rate is about 110, And there is a left axis deviation. You can see usually lead 1 and 2 positive, then it will be normal cardiac axis. So there's some left axis deviation. And the most striking abnormality is there is ST elevation over V1 all the way to V5. And also there's, what is this wave?
This is a pathological Q wave.
Yes, there is a Q wave over V1 to V4. So you have to mention also the Q wave, because what does presence of Q wave means?
I think it is also a finding that would be seen in MI, or could be due to previous MI could also produce Q wave. So I'd like to compare with previous ECG and correlate with the clinical findings.
Very good. So presence of usually in ST elevation, the first ECG sign is hyperacute T, is tau T, and then ST elevation, and then you have T inversion, and then Q wave. So Q wave signify maybe a late presenter, and there of course it can be an old anterior MI now become an VMI in the same territory. So presence of Q wave, but doesn't mean that it is beyond the therapeutic window. So you still need to take the history. If the patient has chest pain onset within 12 hours, this patient is still eligible for revascularization therapy. So the final diagnosis is this patient is having acute anterior ST elevation MI. So how would you manage this patient?
So this is a case of acute MI, so I immediately would like to assess the patient firstly by looking at the airway, breathing, and the circulation, as suggested in in the information. The patient is a dyspneic, so I consider giving the patient nasal cannula oxygen support. As this is a case of acute MI, I would urgently consult a cardiac team to consider primary PCI treatment, and I'll also prescribe the patient with immediate oral aspirin before the PCI, and
Yes.
also serial.
Excellent. So in the short case station, so you will have 4 minutes. So 2 minutes will be for the findings, and 2 minutes for the diagnosis, another 2 minutes for the management. So what you say is almost everything covered here. So management, you used to say in the examination is a medical emergency, and I will attend the patient immediately, and then assess the need for resuscitation according to the ACLS guideline. So I will attach the patient to cardiac monitor with defibrillation standby, set up the IV access, take a targeted history and physical examination, give the patient loading dose of aspirin 320 milligrams, that treatable if not absolute contraindicated, such as no history of angioedema and anaphylaxis. GI bleeding per se is not a contraindication. And we have to consider revascularization as soon as possible. And usually primary PCI is the preferred option over the thrombolytic therapy. So I will consult the cardiologist to see the patient immediately. So say if this patient, if there's no primary PCI service available, so if you were to give the thrombolytic, so what are the contraindications of thrombolytics?
It's the contraindication for thrombolytic therapy would be a bleeding tendency. So before prescribing thrombolytic therapy, I'd like to order the blood test of the patient, INR, clotting profile.
So would you wait for the result before you give thrombolytic?
I will not wait for the...
You know the turnaround time for the troponin T, the turnaround time for the clotting profile, and also the turnaround time for the complete blood count.
I think it would probably take a few hours, so I wouldn't wait for a blood test, but I also like to rule out some impossible...
But you would take the history of medication use, right?
Yes.
So if the patient is on warfarin, or the patient is on NOAC, or the novel anticoagulation, and then probably thrombolytic is a relative contraindicated because of the patient is already on some anticoagulation. Adding thrombolytic therapy on top will increase the bleeding risk. So I think history would cover that part. So what else?
I think aortic dissection is also an important
Yes.
so I will order chest X-ray, look for any wider mediastinum, and review the history to see if there's any typical chest pain of suggestive of aortic dissection. And in A&E settings, I may consider doing a V scan to look at any pericardial effusion or any ascending aortic dissection.
Okay, very good. So basically, everything is in your Houseman handbook. So contraindication to thrombolytic therapy, you divide it into absolute or relative contraindication. So history of ICH anytime. So malignant intracranial neoplasm, ischemic stroke within 3 months, AV malformation in the brain, active bleeding, suspect aortic dissection, and those are absolute contraindication. And you cannot consider to give this patient thrombolytic. And for relative contraindication, I think I would also avoid thrombolytic, especially nowadays primary PCI service is available in nearly all public hospitals. So primary PCI is still the treatment of choice if the patient is having STEMI. And if primary PCI is not available in one hospital, one can transfer to another hospital for primary PCI. So that is usually asked, common question being asked in the examination. So 考試就係咁樣考咯，即係問嘅問題其實同我頭先問嘅其實係一樣嘅，就會問你QA 代表咩啦？有啲咩 diagnosis 啦？點 manage 個 patient 啦？有咩 contraindication thrombolytic? This is all standard questions being asked. So memorize all those and you score very high mark in this aspect. So other treatments, so beta blocker, and you especially used in patients with systolic heart failure or systolic dysfunction if EF less than or equal to 40. But mind you, beta blocker is contraindicated in asthma, bradycardia, and heart block, ACI, and especially used in patients with hypertension and diabetes, and also maybe ejection fraction less than 40. But you have to watch out for the first dose hypotension effects, especially after massive infarct. If you gave the patient ACI too early, the patient may have hypotension immediate after the first dose. And also lipid lowering agent. In all patients, we gave high dose statin in respect to the baseline LDL level, such as most Crestor 20 milligram or Lipitor 40 milligram. So if the LDL is more than 1.8 despite high dose statin, we will give acetamide. And if both drugs, if a patient on both drugs, but the LDL remain high, more than 1.8, then we would consider adding PCSK9. So case number 2. So anyone here? So you have to be quick because if you can answer quickly, we can go through more cases. 唔使怕醜，真係我唔識你噶嘛。So I will guide you through, don't worry. So anyone? Actually, those cases are real case as well as similar case to your examination.
Hi.
Hi, excellent. So thank you very much. So the second case is a female, neck 69, hypertension, diabetes, hyperlipidemia, presented with chest pain for 2 hours, associated with dizziness, nausea, and sweating. Mind you, sweating is a very important symptom. So when you have chest pain associated with sweating, usually this patient is either having MI or dissection. So remember this piece of history is very important. So if you have abdominal pain and sweating, it may be vagal reaction. But if you have chest pain, severe chest pain, and associated with sweating, usually it is MI or dissection. No syncope, no shortness of breath. So blood pressure is 80/40 and the pulse is 40. There's no murmur. So this is the EKG. So what is the ECG findings?
So this is the ECG of this patient showing first of all, the heart rate is a bit low in 49 beat per minute. Probably a sign of bradycardia, and also one of the striking features would be ST elevations over the lead 2, 3, and AVF. So this is probably a case of inferior MI.
Excellent. So why is the heart rate so slow?
Also, there is a complete heart block.
So I hope everyone can see. So can you see my pointer in the computers?
Yes.
Okay, so this is the P wave, the first P wave in lead 2. This is the second P wave. And actually the third P wave is buried inside the T wave. So there's maybe a P wave here. P wave here, the P wave here, here, here. And this P wave is just coincide with the T wave. This P wave is coincide with the QRS complex. So there's evidence of AV dissociation. So this is a complete heart block. So it's quite common in inferior myocardial infarction. This patient would have complicated with complete heart block and bradycardia. So how about the ECG in V2? So any special thing about the V2? So do you expect the QRS R wave transition in so early happen in lead 2? So what is this signify? So also there's ST depression in V2, right?
Is it a posterior MI?
Yes, excellent. So this patient developed ventricular fibrillation and requiring defibrillation in the A&E. So this is the EKG or ECG after the DC shock, actually the defibrillation. So you can appreciate that there is evidence of complete heart block and ST elevation over lead 2, 3 AVF, reciprocal ST depression over lead 1 and AVL, and also there's ST depression and dominant R wave in V2, suggestive of posterior infarct. So I will explain a bit about the posterior infarct. So you know what is reciprocal change? So like in this, do you see my diagram clearly? So in the right hand side. So this is the heart, and this is the right coronary artery on the here left side, and this is the left main. So the left main will bifurcate into the LAD, and also the circumflex artery. So this is the wheel when you look in front of your heart. So this is the cardiac axis. So this is lead 1, where the lead 1 will locate. This is lead 2, lead 3, AVF, AVL, and AVR. So when you have RCA occlusion, so you block the RCA, so the ST segment injury has a vector. So it will point towards the lead 3 side. So usually the lead 3 would have the most ST elevation when compared to AVF and lead 2. You understand what I mean? Because of the vector point towards lead 3. So you have ST depression in the opposite lead, such as lead 1 and AVL. So this is what we call reciprocal change. So you will see if it is the inferior MI is due to RCA territory, then the lead 3 ST elevation would be higher than lead 2 and AVL, and there will be reciprocal ST depression in lead 1 and AVL. So this is what we mean by reciprocal change. How about the posterior leaks? So if you have posterior MI, where is the reciprocal change? It would be anterior, right? So in this ECG, is actually, if you turn upside down lead 2, the dominant R wave is actually the Q wave. The ST depression is actually the ST elevation. You have the upright T would signify that this patient, there would be T inversion if you upside down to look at it. So in this case, the most correct diagnosis would be acute infraposterior MI complicated with complete AV block. So this patient is hypotensive. The blood pressure is 80/40. So for every cases with inferior MI, you have to look for evidence of RV infarction. So we usually also do the right side ECG leaks and look for the RV4 leaks, the right side V4R leaks. And if there's evidence of S deterioration in the right side ECG leaks, then this patient is having RV infarction at the same time. So this is the anatomy of the RCA. So you will have a conus branch. You have this sinus node artery, which supply the sinus node. You have the RV branch, supply the RV, the marginal branch, the posterior descending branch supplying the posterior wall, posterolateral branch supply the lateral wall, and also the AV nodal artery, so atrioventricular nodal artery supply the AV node. So this RCA infarction can have posterior MI, lateral MI, AV block, RV infarction, or even ischemia to the sinus node result in sinus bradycardia, junctional bradycardia, or even sinus pause. So these are the possible things you need to look for. If you are given a case of inferior MI, you have to look for all those like posterior MI, lateral MI, AV block, RV infarction. So the investigation you would like to request, what would be the investigation you would like to request?
So I will do a blood test. I will check the troponin level and also want to do a chest X-ray, and also also the blood test will look at the CK level, and also the clotting profile, lipid profile, and renal and liver function test.
Say all are correct, but of course management would be the same as last case. You have to attend the patient immediately, and resuscitation if needed, and then attach the patient to cardiac monitor with defibrillator function, set up the IV access, and then take a target history, focus examination, and aspirin if not contraindicated, give the patient, consider the mode of revascularization, primary PCI, and then since the patient has bradycardia and RV infarction, so I would give the IV fluid and also some inotropic support, and may consider pacing if there's significant bradycardia with hypotension. And the investigation would be you want to look for posterior MI, so you do the posterior ECG. You want to look for RV infarcts, and you would like to do the RV ECG leaks. You also like to request, and I mean, if the cardiologist is there, they would like to do the echo to confirm whether there is any RV involvement, etc. So for RV infarction, so you can give cautious IV fluid, especially you can give some IV fluid to the patient, but mind you, excess IV fluid may cause fluid overload. So you have to be cautious in giving small boluses each time and assess the clinical condition. So in case of RV infarction, you need to avoid nitrate, diuretics, and morphine, because those may cause hypotension. And inotropic support such as dopamine and dobutamine, urgent reperfusion therapy, and also sometime in severe RV shock, we may need to give the patient percutaneous RV assist device. So this is the third case. Any volunteer?
Hi, I can give it a shot.
Yeah, thank you very much. So the third case is a 76-year-old male, non-smoker, social drinker. Hypertension is impaired fasting glucose, and he was admitted for chest pain for 30 minutes and then resolved. The chest pain is retrosternal and radiate to the neck and upper arm, and there's no radiation to the back. And we did the ECG and the patient is pain-free. So this is the ECG. So what is your what is the ECG findings?
Okay, so this is sinus with a normal axis. The rate seems regular to me. Narrow complexes. There's no evidence of heart block. There's T-wave, well, sort of widespread T-wave inversion from the anterior to the lateral leads. With slight ST elevation at the J points in V2 to 3, but not meeting criteria, I think.
Excellent.
This
So
this may be just ischemia, but the T-wave inversions are really quite deep. So
what is your diagnosis?
Diagnosis may be non-STEMI.
Yes, but what is NSTEMI? So you need to have elevated cardiac enzyme to diagnose as NSTEMI, right? So right. I haven't gave you the enzyme level, so you can't say it is a NSTEMI. But you are quite right that this is a case of acute coronary syndrome. So the reason is, so this patient is present with typical exertional chest pain, and it's quite recent onset with deep T inversion. So this has to be a case of ACS. But any special syndrome you know of about this ECG pattern?
So could it be type A Wellens?
Yes, excellent. So this is a case of Wellens syndrome. So it's a specific type of ECG pattern described by Dr. Wellen. So usually he described a series of patients that during pain, the ECG has a normal T, but after the pain subside, and there's either a biphasic T wave or symmetrical deep T wave inversion over the anterior leads. And this is a case of Wellens syndrome. So usually, why is Wellens important? This is a very, very, very high risk ACS situation. So usually associated with a critical stenosis in the proximal LAD, usually 95-99%. And if left untreated, the mean day to massive anterior MI is 8 days. So if you discharge the patient, and the patient will surely be admitted for massive MI. So you have to recognize this pattern. Otherwise, if you discharge the patient may die at home or present again to you with anterior MI. So recognize this pattern. So type A or B doesn't matter. Type A means biphasic TVA inversion. Type B means deep T inversion. So my case is actually a type B, you may say. But both A and B is the same. Critical stenosis in the proximal LAD. And LAD is very important. If you have infarcted the LAD territory, the patient, even if he or she can survive, and he will have a refractory heart failure, poor ejection fraction. So recognize this pattern. Do coronary angiogram PCI as soon as the patient is presented. At least you have to do coronary angiogram and PCI within the hospitalization, and do not discharge this patient. So fourth case, so any volunteer. So recognize this Wellens syndrome, very important.會試下逼你答問題咁，但係其實咧係咯，咁樣會學得多啲。So any volunteer?
Hello.
Oh, thank you very much. Thank you. So the fourth case is 62 years old ladies, hypertension, diabetes, hyperlipidemia, so vomiting and then chest pain. And then attended A&E, and there's still ongoing chest pain, blood pressure was stable. And this is the ECG. So what is the ECG findings?
So the rate is fast with 150 beat per minute. There is There is no discernible P wave.
Yes. So what is this?
So I'm suspecting atrial fibrillation.
Yes, this is a
or,
case of atrial fibrillation with fast ventricular response rate, and the rate is 140 as written in the top left-hand corner. And so you are correctly point out that this is a fast AF. So what else do you find? Excellent. How about the ST segment?
There are diffuse ST depression over, especially over the chest lead.
Yes.
V2 to V6.
Yes. So what else? Where could you find the ST segment depression?
As well as lead 2, 3, and AVF.
Yes, and then lead 1 as well, right? So how about the AVR? The AVR.
ST elevation.
Yes, excellent. So basically, this is a case of fast AF with rapid ventricular response rate of 140, and there's a diffuse ST depression, very deep ST depression over the precordial leads V2 to V6, and lead 1 and lead 2 AVL, and there's also ST elevation over AVR. So are you worrying about this patient?
I'm worried about triple vessel disease.
Yes, excellent. So what else?
Because
Apart
of
from triple vessel disease, what else?
And also the atrial fibrillation may need a rate control.
So I will talk about it later on. So apart from apart from triple vessel disease, you also need to worry about left main. So so the diagram written drawn on the right hand side. So can you see it? So when you have RC occlusion, so the ST segment vector will be pointing to lead 3. So if you have circumflex occlusion, the ST vector will pointing to lead 2. So if you have circumflex ischemia like causing ST elevation, you will have ST7 elevation more on lead 2 when compared to lead 3. And lead AVL and 1 would be isoelectric or some small amount of ST elevation. So, but you have if your injury vector is towards the AVR, it's either signify a global ischemia like triple vessel disease situation or left main STEMI. So especially if this in the case of left main occlusion, usually the patient will present with shock and hypotension. Because left main is a very important artery that supplies the LAD and circumflex. And patient will have ongoing chest pain and in cardiogenic shock most of the time. So if you see this pattern and the patient is relatively stable, it still signifies significant ischemia, but according to my experience, it's more likely to be triple vessel disease. But anyway, when you see this ECG pattern, isolated ST elevation over AVR or the V1, and then diffuse ST depression in other leads, more than 6 leads with ST depression, it signifies either left main or triple vessel disease. So how would you manage this patient? So this is an end-STEMI situation. So of course, you apart from you keep the patient cardiac monitoring, you check the blood. How about the pharmacological management? Usually is start with A. So we start with aspirin and P2Y12 inhibitors, the antiplatelet treatment. The antithrombin treatment, especially we are using most of the time is low molecular heparin. And anti-anginal treatment such as beta blocker or non-dihydropyridine CCB such as diltiazem if beta blocker is contraindicated, and nitrate. And ACI, especially if the patient also have concurrent hypertension, diabetes, or ejection fraction less than or equal to 40, and lipid-lowering drugs. And of course, early invasive strategy should be performed. In this case, this patient is having a very high risk end STEMI. So we perform the cardiac cath on the next day we show actually distal left main 90% with clot, proximal AD 90%, proximal circumflex 95%, and mid RCA 70%. And we have done the coronary bypass surgery, and the patient made an uneventful recovery. So remember, the more ST segment changes, the more high risk the patient is. So very severe, very alarming ECG. If you ignore this, the patient may die that night or next day. So at least you have to admit the patient to like CCU, consult the cardiologist to see the patient immediately, because this can be a case of left main occlusion. Okay, so case number 5. Again, any volunteer? So I actually got 12 cases in total. So let's see how far can we go.
Hello, can you hear me?
Yes. Thank you very much. Excellent. So case 5 is a case I saw just yesterday. So it's a 30 years old, come from Indonesia, and working as domestic helper and non-smoker. She presented to us actually last month for chest pain for 5 days, and there's sudden acute worsening of chest pain. So the blood pressure is 140/80, the pulse rate is 90, and the ECG is normal sinus rhythm. So can you comment on this chest X-ray?
So this is a frontal chest X-ray of this patient in a sitting position. So the most striking feature would be a widened mediastinum. Compatible with a aortic dissection if combined with a clinical picture.
Yes, excellent. So widened mediastinum, usually is most of the time when you see widened mediastinum, it's not dissection, I would say. But in these young ladies, I would expect the mediastinum to be very narrow, not that wide. But in the old ladies, when you go to the ward and see all the chest X-ray, they all have this kind of so-called widened mediastinum, but most of them don't have aortic dissection. So you correctly point out that you suspect this is a case of aortic dissection, right? How would you confirm your diagnosis?
I will book urgent CT aortogram and consult a cardiothoracic surgeon immediately.
So yes, you are answering correctly. So when in doubt, always compare with old chest X-ray or old ECG. It is very, very important. So in the court, when you miss this widened mediastinum, and the expert will say, oh, the chest X-ray 1 year before showed that actually the mediastinum is normal, but now it's clearly widened. So this is a case of aortic dissection until proven otherwise, right? So when you compare with the same patient last year, the chest X-ray is like this, and now it's widened mediastinum. So this must be a case of aortic dissection combined with the history, right? So further examination. So what is your findings?
So clinical findings, so on the left-hand side, it shows a high arched palate. The middle picture shows long extremities, and the right hand picture shows a hypermobility of the joints. So I would suspect connective tissue disease, specifically Marfan syndrome.
How about these two signs? Do you know what's the name of these two signs?
The left picture is the thumb sign, and the right picture is the wrist sign.
Excellent. So you are winning the gold medal now. So this is the CT. So what is your diagnosis? Describe the CT findings.
So this is a contrast CT aortogram of this patient. So there is a dissection flap, which is involving the ascending aorta. So this is a Stanford type A aortic dissection.
Excellent. So you know everything. So you can see there's a dissection flap, basically, and also the dilated ascending aorta, right? and also dissection flap in the descending aorta, and also the dissection flap extending to the arch. So you have two different classification of aortic dissection. One is Stanford classification. Is type A means the patient has aortic dissection involving the ascending aorta and may progress to involve the arch and descending aorta. Type B means it involves only the descending aorta distal to the subclavian artery without involving the ascending aorta. So this is the usual classification that we are using. The Stanford criteria is simpler. And the other classification is the Baker classification. Type 1 means the ascending aorta, arch, and descending aorta, and may also progress to involve the abdominal aorta. So type 2 means only the ascending aorta. Type 3A means distal thoracic, descending thoracic aorta, distal to the subclavian but proximal to the iliac. Type 3B is thoracic and abdominal aorta, distal to the subclavian artery. So we use usually the Stanford criteria because this is simpler. And if you have ascending aorta involved, this is type A. Ascending aorta not involved, this is type B. So it's as simply as that. You correctly mentioned that this is a surgical emergency. You need to urgently consult your cardiothoracic surgeon. And every 1 hour, the patient will die suddenly because of the type A dissection. The type A dissection can retrograde dissect into the pericardium, causing hemopericardium and die of PEA arrest. And you have to admit the patient to CCU, set the A-line for blood pressure monitoring, also blood taking, including the type and screen. Immediately control the blood pressure while waiting for the surgery by IV, intravenous labetalol, plus or minus nitroprusside. So it's still on you. It's a long case. So we admitted 2 weeks after discharge. I mean, actually, she was in hospital for 1 week or 1 or 2 weeks and then discharged. And then we admit around 3 weeks follow-up. So for shortness of breath. So this is the ECG. So still on you. What is the ECG findings?
So this is the ECG of this patient. A striking feature would be the low voltage over all of the leads, as well as a.
How about the heart rate?
The heart rate is slightly tachycardic of around.
Is it a sinus rhythm?
It's a sinus rhythm, but the PR interval is increased.
Okay, so normal you would say is 200. Some may say 210. So this is 204. So it's borderline. Okay, so sinus tachycardia, low voltage, and also how about the lead 1? So and lead 2. So do you see any special pattern?
So is it the S1Q?
This is just a white bundle branch block, right? So sinus tachycardia, white bundle branch block, and low voltage. So how would you define low voltage?
I'm sorry, I really don't know.
Hey, no problem. You answer all questions brilliantly. So always when you compare with the ECG before the patient was admitted when the patient before the operation, so you can see that the voltage is normal. But now you have tachycardia with more voltage. So what do you suspect?
So I suspect pericardial effusion because the chest X-ray also shows a globular-shaped heart.
I can tell you the admission officers and also the case MO missed this, and for a week. So I picked it up yesterday, and patient is doing fine after pericardiocentesis. But always compare with old chest X-ray and ECG. You would find a lot of things. So after operation with AVR, this patient had right bundle branch block. It can be a post-operative change, but definitely there is sinus tachycardia with small voltage. And small voltage is defined as less than 5 millimeters in limb leaks, and less than 10 millimeters and or less than 10 millimeters in the precordial leaks. But mind you, from the heart to the surface of the skin, you got like pool space, you have the lung, you have the chest wall, you have the skin, you have subcutaneous tissue. So if you have a very obese patient, the voltage will be small. If you have COPD patient, the voltage may also be small. If you have a very thin patient, then the voltage will be large, right? If you have generalized edema because of heart failure or hyperalbuminemia, because of the edema, the voltage will also be small. It doesn't always signify it's a pericardial effusion, but given the context of post-surgical treatment, there's a risk of like Stressler syndrome, post-surgical pericardial effusion is quite common. So you have to suspect, especially this case, it's just post-op with a Bentor surgery done. So this is the echo. So although I know you may not know echo, but what is your diagnosis?
So the echo finding shows a right ventricular collapse.
Yes, you correctly point out this. And what is this?
There is also pericardial effusion.
Yes, so there is a pericardial effusion and also diastolic RV collapse suggestive of cardiac tamponade. So this is normal. So this is the mitral valve. This patient undergo a wood replacement and also aortic valve replacement. So this is a Bentor surgery. Replace all the wood and also with an aortic valve with a mechanical aortic valve. So this is the LV. This is the mitral valve. This is the LA. This is the RV. And you can see there's pericardial effusion surrounding the heart. And this is the sternal long access wheel. This is a short access wheel. This is the pericardial effusion. You can see the heart is swimming inside the pericardium. And this is the 4-chamber wheel. This is the LV, LA, mitral valve. This is the RV, RA. And this is a large pericardial effusion compressing on the ILA and also the RV. This is a subcostal wheel. You can see on this diagram, should be the liver and the heart. And this is pericardial effusion, very large pericardial effusion compressing on the RV or on diastole, suggestive of pericardial tamponade. So after talking about 2 cases of STEMI, 2 cases of NSTEMI, and also 1 case of acute aortic dissection, I will talk briefly how to approach a patient with acute chest pain. So this is actually a question asked during an intern interview in QEH. So the question asked is, say a 50 years old gentleman present to you with sudden onset severe chest pain. Now the blood pressure is 70/40, heart rate is 110. How would you manage this patient? So think about this is a question they selected MO in QEH in the past. So always, when you approach a patient with acute severe chest pain, not in the outpatient, but in A&E or in the ward, you have to rule out the life-threatening causes of chest pain. So what are those? Those are AMI, aortic dissection, and PE, tension pneumothorax, or ruptured esophagus. Ruptured esophagus can be due to foreign body injection. 啃骨咧就係可以考到ruptured esophagus 嘅 or chemical, iatrogenic or spontaneous. So I remember more than 10 years ago, that is not my patient, but another doctor's patient. So that patient was admitted after 啃咗啲鴨骨, and then he complained of persistent chest pain. And the admission officer say acute chest pain to medical ward, and then the medical officer just take the ECG troponin for 2 days, and there's no serial change, and think that this patient is having a atypical chest pain. but this patient also gave a history of choking of duct bone. So later, this patient developed surgical emphysema and septicemic shock, and then requiring intubation. After intubation, the surgical emphysema worsened, and the CT confirmed that it is ruptured esophagus with mediastinitis. And so remember, so if the patient give a history of foreign body injection, so think about ruptured esophagus. It can also be spontaneous, such as Pohavy syndrome or iatrogenic after the OGD or ERCP. So when the patient has chest pain, and if you do the history taking and examination, and then you do the ECG. So if there's ST elevation, this is a case of ST elevation MI. If there's no ST elevation, we check the enzyme. So if you have enzyme elevation, then it is non-ST elevation MI. You can have T inversion or ST depression, as in my 2 cases of NSTEMI. And if you have no enzyme rise, but your history is suggestive of unstable angina, then this is unstable angina. So unstable angina is usually defined as new onset of angina within 3 months, or pre-existing angina, but the patient has worsening of the angina in terms of the frequency and severity. So just say 如果病人咧話俾你聽咧，我行路咧個心就揦住，咁咧就唞一唞咧就好啲嘅，咁咧就幾分鐘就好啲噶啦，咁咧就係呢個月開始嘅。咁而家咧就之前我跑步都得嘅，而家我行少少斜路咧個心就揦住行唔到噶啦。咁咧就 so this is already unstable angina. So why? Because this is a new onset of angina within 3 months. And if you check ECG, troponin, all normal, but the history is very, very suggestive of unstable angina given the new onset of angina. You have to admit the patient or refer the patient to A&E. And if I saw this patient, I would do the coronary angiogram as an inpatient procedures. 另外一種咧就係、另外一類咧就係佢本身有angina 嘅，咁但係話俾你聽咧就最近呢排咧就密咗，之前可能行1層樓梯就翳㗎啦，而家咧就行3級都翳咁樣咧，咁 this is also unstable angina. So history is the most important piece of information in diagnosing unstable angina. And the other thing is you could also have ECG change, but resting ECG is usually normal in unstable angina. Sometimes you may have T inversion, sometimes you may have ST depression, but most of the time it's normal. So history is very important. So this is the guideline published in Circulation 2012. It's a joint guideline for many societies for evaluation of diagnosis of chest pain. So it still emphasizes that careful history taking is the most important. So when you have chest pain, that is central exertional related retrosternal that come and go in few minutes or more, then it is more likely to be an angina. So if you have sharp pain, say very sharp pain, pleuritic pain, or can localize to 1 finger, then this is not, or last for 1 second or 2 seconds, then this is not angina. The probability of ischemia is very, very low. So you have to differentiate whether the patient has cardiac versus the non-cardiac chest pain. Nowadays, the guidelines say you have to differentiate cardiac versus non-cardiac instead of saying that this is a typical chest pain. So the next investigation would be ECG and troponin T. So this is a very busy slide, and I'm not going to go through it, but this is the table saying that what are the characteristics of the chest pain, such as the nature, onset, duration, location, severity, precipitating, relieving factors, associated symptoms. It is basically the history taking. So what are the important points you need to note in the history taking? And also the examination, you look for like any blood pressure difference, any AR murmur, because aortic dissection can cause acute AR. And for like esophageal rupture, you can have subcutaneous emphysema, sometimes pneumothorax, absent breath sound, etc. If you have pericarditis, you may have like rub, and you may have some sign of pneumonia, etc. So this is the slide put in the guideline telling you how to take a good history. So good history is very important, and then do the ECG. And then if you have ST elevation, then this is a STEMI. If no ST elevation, then you check the enzyme. If the history is suggestive of angina, new onset or worsening angina, despite the normal EKG or troponin, you still need to suspect this is a case of unstable angina. You may diagnose PE or etc. So troponin T is very sensitive with picking up myocardial site damage. So if you have elevation more than 5-fold, then you have 90% chance this is a case of type 1 MI. So if you have 3-fold upper limit of normal, then 50 to 60% you will be a case of MI. So it's quite common to detect circulating troponin in healthy patients, especially after long distance run, heavy strenuous exercise. But usually in acute MI, there's a typical rise and fall. So sometimes in patient with renal failure, end-stage renal failure, the troponin can be mildly elevated, but usually the level will be static. Like the normal would be in our hospital, the high sensitivity troponin T, the normal is less than 40. So if the patient has end-stage renal failure on dialysis, he or she can have troponin level 100 or 200, but the level will be staying the same, 200, 200, 200. Then this is not the typical rise and fall of MI. So other conditions can also be associated with cardiomyocyte injury, such as tachyarrhythmia, heart failure, hypertensive crisis, myocarditis, aortic dissection, PE, etc., renal failure. So we rely on the history taking mostly, and then ECG troponin, and to diagnose whether it's STEMI, NSTEMI, unstable angina, or non-cardiac chest pain. If the history is not suggestive of cardiac in origin, normal ECG, normal troponin, then you have to evaluate for other causes such as GI cause, chest, or musculoskeletal causes. So in patients with ACS, there's we also would do some say NSTEMI or unstable angina. Then we would do some risk assessment of those patients. Usually we would look at the ECG biomarkers such as troponin, clinical score, and the gray score is commonly used to assess the risk of dying in patients with ACS. So ECG is very useful. Say if the patient has significant ST depression, this is high risk. So it's a quantitative markers of risk. So if there's the number, if there's a very deep ST depression and many leaks that has ST depression, it indicates he or she may have an extensive area of ischemia and is correlate with the prognosis. So when you see very striking ST depression, this is a high risk ACS, and you still need to consider admit the patient to CCU with early invasive coronary angiogram and PCI. And if you have T inversion, usually the prognostic value is less than ST depression, but deep T inversion may signify ischemic change, i.e. the Whelan syndrome. The troponin T also adds prognostic information to the short-term and long-term mortality. So the higher the troponin level, the greater the risk of death in patients with ACS. And this is the gray score. And you take into account of the age, history of heart failure, MI, heart rate, systolic blood pressure, depressed ST segment, and this is the, elevated cardiac enzyme, serum creatinine, any percutaneous revascularization, and then you add all 9 points together. So if it is 140, then the patient is considered as high risk. So I would skip this and then go to the 6 cases. And any volunteer? So if the patient has high-risk ACS, say there's significant ST depression, elevated troponin, ongoing chest pain, unstable hemodynamic, high gray score, then I will recommend an inpatient coronary angiogram and PCI. So if the patient has low risk, say absent of all those high-risk features, then you can do further risk stratification with either CT coronary angiogram or stress test before considering into invasive coronary angiogram and PCI. So this is usually the management strategy apart from pharmacological treatment I mentioned before. So any volunteer for case number 6?
Hello. Can you hear me?
Hi. So, thank you very much. So, this is 24 years old ladies, ex-smoker. So, he present to actually another hospital for hemoptysis, and then she was treated as chest infection, and this is the chest X-ray of this patient, and this is a ECG. So this patient, after discharge from another hospital, we attend to our hospital for the same problem, hemoptysis. So she was admitted to medical ward, and this is the ECG of this patient. What is your findings?
So this is the ECG taken for the young lady. The pulse rate is 61 beats per minute, sinus with P wave seen, and the QRS complex is not prolonged. However, it's noted that there are ST depression noted in lead 2, 3, AVF V2. Because it's diffusely involved, associated with some T wave inversion.
Yes. So how about the cardiac access?
The cardiac access is normal. The lead one, it's right axis deviation.
Yes, it's right axis deviation. So how about the R-wave progression in the precordial leaks? Anything abnormal? So usually, in normal ECG, you got progressive R-wave increase in the R-wave from V1 to V6, right?
Yes. I think the R wave is tall, very tall.
Yes, very tall R wave in V1 and V2.
Could suggest a right ventricular hypertrophy.
Yes, excellent. So you made your diagnosis. So what do you suspect in this case?
This is a young lady presented with hemoptysis associated with right ventricular hypertrophy. Could indicate pulmonary, possibly suggesting some pulmonary causes. So I would like to rule out pulmonary embolism as the most life-threatening cause.
Yes.
I may consider urgent CT pulmonary angiogram.
Yes.
To confirm or rule out the diagnosis of P.
Yes, excellent. So the first thing to rule out in this young lady is pulmonary embolism. So because this patient, although there's no tachycardia, but massive PE sometimes can have bradycardia. And dominant right axis deviation, dominant R-wave in V1. Although this case finally diagnosed to have primary pulmonary hypertension, but the first thing to come in mind, especially in patients with hemoptysis, is you have to rule out PE. So what are the diagnostic criteria of right ventricular hypertrophy? You have dominant R wave in V1, so the R to S ratio is more than 1, and also the R wave in V1 is more than 6, so it met the criteria of RH, right? So you have right bundle branch block. You have also S1Q3T3. So this is a sign of this is a ECG findings of a patient with right ventricular hypertrophy or right heart strain. So the first thing you need to do the urgent CT in order to rule out the patient is having actually the pulmonary embolism, sometimes pulmonary embolism causing pulmonary infarction and hemoptysis. So this is the echo. So you can see this is the LV is being compressed by the enlarged RV. So you can see that the LV is being compressed by the RV with a D-shaped ventricle. So this is the right ventricle is compressing on the left ventricle, and the RV is very thick. So this is a chronic process. So if you have a pulmonary embolism, the RV wall is thin. So usually the cutoff is 6 millimeters. If you have more than 6 millimeters, then it has less, then it is likely to be acute. So we do the CT, no PE, and the echo show is severe pulmonary hypertension, and the LV function is normal. So that final diagnosis is idiopathic pulmonary hypertension. And hemoptysis is actually one of the presentation of idiopathic pulmonary hypertension. Okay, so any volunteer?
Oh, hi, can you hear me?
Yes, thank you very much. So this patient is a young gentleman, 41 years old, admitted to AED for blurring of vision after seeing eye, and the eye say there's a grade 4 fundal changes. So the blood pressure at A&E is 240, diastolics is 189, and the pulse is 140. So this is the admission notes, and this is the ECG. So what is your findings?
This is ECG of this patient. There's a long the R wave in V2 and S wave in V6. This is a left ventricular hypertrophy.
Yes, what criteria are you using?
I'm using the voltage criteria.
Yes. So the S wave in V2 and R wave in V5, adding more than 35, then this is clearly the LVH. And what's the cardiac access? So it's easy. So V1, V2 positive, and LIC1 and LIC2 positive, then this is normal. Yes. And with a sinus tachycardia. So sinus tachycardia, normal cardiac access, severe left ventricular hypertrophy, S wave and R wave added together more than 35, and there's also some string pattern with some ST depression over V5 to V6. So because of the confusion, he was taken to the CT, and CT brain was taken. So what is your findings?
This is a non-contrast CT brain in axial cut. So I think there is a bilateral infarct of the brain.
It's not infarct, but basically you can see the gray white matter is abnormal. The white matter is abnormal. So what is these changes?
Is it a cerebral edema?
Yes, because malignant hypertension can cause cerebral edema. Sometimes edema occur only in the posterior circulation. So this is called posterior reversible leukoencephalopathy, PRES, PRES. And because the posterior circulation has a poor cerebral autoregulation, so usually it's affected earlier than the frontal part of the brain. But this case has a diffuse cerebral edema. Sometimes you compare both sides, you can say this is normal because both sides are normal. But you can see, can you see my pointer here?
Yes.
So there is a small dot of hemorrhage. This is some small hemorrhagic changes in the maybe the left frontal lobe, or yes. So how would you manage this patient? What is your diagnosis?
So this is a hypertensive emergency. So I would like to see if there's need for resuscitation according to the ABC principle. Make sure the airway is patient, and also give oxygen and establish IPSs.
Yes,
So
excellent.
Either giving labetalol to the patient.
Yes, excellent. So very good. Basically, it's a hypertensive emergency with grade 4 fundal changes. cerebral edema, and also small ICH. So he will need to, we will admit the patient to either CCU or ICU. We have to lower the blood pressure with some intravenous antihypertensive drugs, preferably the IV labetalol, plus or minus the nitroprusside infusion with A-line, the arterial line monitoring. So we have to cautiously lower the blood pressure because of the disrupted cerebral autoregulation. So because precipitant lowering of blood pressure can induce cerebral ischemia, it's usually safe to lower the MAP by 25% or the diastolic blood pressure to 100 or 110 in the first 24 hours, but not too aggressively because sometimes it may cause bilateral cerebral ischemia due to the disrupted cerebral circulation in case of malignant hypertension. So next 20 minutes, I'm going to talk about some of the arrhythmia. And usually the mechanism of arrhythmia is 90% is due to re-entry, and secondly is automaticity. The third mechanism is delay after repolarization. So this is the mechanism of the re-entry. So I would like to explain it in Cantonese. 你如果要有re-entry 咧，咁咧就首先咧我哋有一個嘅pathway、slow pathway， 同埋一個叫 fast pathway， 即係等於咧你由舉個例荃灣啦入屯門，咁你可以行呢個屯門公路啦，同埋呢個青山公路嘅。咁咧就傻嘅都唔會行青山公路啦，無啦啦，除非屯門公路塞車嘅啫，因為快啲啊嘛。咁咧就所以咧正常嚟講咧，你都係由個屯門公路去屯門嘅。咁但係咧就當你有一個 premature beat 嚟到，而呢個 fast pathway 咧係仲係喺個 refractory period 嘅時候咧，即係撞咗車啦屯門公路，咁你咪行青山公路咯。咁你行青山公路嚟到呢度咧，佢啲 electro current 咧，其實可以上翻去嘅喎，咁亦都可以落去啦咁樣。咁如果上翻去咁啱呢度咧，亦都係可以 conduct 到嘅話咧，佢就會繼續喺度打圈咯。咁呢個就係一個 re-entry circuit。首先咧，你要一個 slow pathway、fast pathway， 同埋一個 appropriately time 嘅 premature beat。咁咧就可以 trigger 到一個叫 re-entry 啦。So the other mechanism is automaticity. And so how would you approach a patient with arrhythmia? Usually I would assess the hemodynamical stabilities, attend the patient, assess the need for any resuscitation. And then when you see the arrhythmia, you attach the patient to cardiac monitor with defibrillation standby. Then you look at the arrhythmia, analyze it by asking yourself two questions, whether it is a narrow complex. If it's a tachycardia, then whether it's a narrow complex or wide complex, and whether it is regular or irregular. So if it is a narrow complex defined by QRS less than 120 and irregular, then it could be either a case of SVT or atrial flutter. SVT is either atrial tachycardia, AV node reentry tachycardia, or AV reentry tachycardia. If it is irregular, then it could be atrial fibrillation, atrial flutter with variable block, or multifocal atrial tachycardia, and usually occur in patients with COPD. So this is AV node reentry tachycardia. It happens when the reentry circuit is in the AV node. And usually there's no P wave seen or there's a retrograde P seen immediately after the QRS. And you don't need to differentiate this, but you have an idea that SVT can be having a free mechanism. And this is AV reentry tachycardia. Usually the AV groove cannot conduct electricity or current from usually if you have electrical signal from atrium, it has to go through the AV node. The other part is not. Sorry, can you see my slide? Oh, 唔該晒。So the other mechanism is AV reentry tachycardia is that you have a pathway and the reentry circuits go through the AV node and then go back through the pathway into the atrium, and then atrium go back to the AV node. Establish a so-called AV reentry tachycardia. Atrial tachycardia is some automaticity or reentry circuit in the atrium that continuously fire and then transmitted to the ventricle. So you also have atrial fibrillation, atrial flutter, that I think you all know this. So when you have Y complex tachycardia, you differentiate it into regular or irregular. So if you're a regular Y complex tachycardia, it can be either ventricular tachycardia, you can be SVT but with aberrant conduction. The third one is very difficult to understand, and perhaps you can forget about it. Is antidromic reciprocating tachycardia. That means for usually if SVT due to AV reentry circuit, it goes to the AV node and then come back to the atrium through the pathway. But if you have, this is orthodromic reciprocating tachycardia. So it's go through the AV node down to the ventricle and then come back through the pathway to the atrium. So how about if the reverse is antidromic? So you go through the pathway down to the ventricle and then come back through the AV node into the atrium. Then you will go through those ventricular muscles, so the QRS will be widened. If you go through the His-Purkinje system, the QRS will be narrow. So this is what we call the antidromic reciprocating tachycardia. So if you have irregular Y complex tachycardia, it can be either polymorphic VT, atrial fibrillation pre-existing or functional block, or AF with pre-excitation, such as Wolff-Parkinson-White syndrome. So 有冇人 volunteer 咧？講多兩個 case 啦，係啦，有冇 any volunteer？
Hello, maybe I can try.
Thank you very much. So this is 21 years old. Actually, this happened in examination. The case I asked you mostly asked in the either the written exam or the short cases. So this is the usually expected answers I gave you. So this one is also examined before. So as 21 years old, recurrent palpitation attack, blood pressure was stable. So this is the ECG. What is your diagnosis?
So this is the ECG of the young gentleman with palpitations. So this is a regular narrow complex tachycardia of around 150 beats per minute.
What is your diagnosis?
And there's also no discernible P waves. So I would suspect a supraventricular tachycardia.
Excellent. So you know what? In the examination, some students say this is a ventricular tachycardia. Some say it's sinus tachycardia. Some say it's many different interesting things. And only 30% of you answer it correctly. But it's just as simple as that. This is a supraventricular tachycardia. So how would you manage this patient? So it's easy. So when you see this ECG, it's regular, it's narrow. So it can be either SVT or atrial flutter. So your answer in this case, you don't see the flutter wave. So this is SVT. And within SVT, you could have atrial tachycardia, AV reentry tachycardia, or AV node reentry tachycardia. But this doesn't matter. What we want you to answer is SVT. Remember. 竟然有人答唔到，好多人答唔到，不過好叻，係啦。So how would you manage this patient?
So first of all, I would like to assess the hemodynamic stability of this patient. So
yes. If the patient is unstable, what will you do?
Then I would go for a synchronized cardioversion.
Excellent. So remember, in exam, if you do cardioversion, you need to synchronize with the R wave. And you do defibrillation only in case of cardiac arrest situation. So don't say you want to defibrillate this patient, you will be strict fail because you say defibrillation in this case. you will do harm to the patient, and you will induce ventricular fibrillation. And the patient, if you shock on the T wave, then the patient may run into ventricular fibrillation, and you may not be able to shock the patient back to sinus. So only in cardiac arrest situation, ventricular fibrillation or pulseless VT, then you will do CPR and defibrillate the patient. So in case of arrhythmia with hemodynamical compromise, you do cardioversion, that is synchronize the shock with the R wave. And what energy would you use?
50 to 100 joules.
Yes, excellent. So you know everything. So if the patient is stable, how would you manage?
If the patient is stable, then maybe we can first attempt some phago maneuvers. If that fails, then we can try IV bolus of ATP of 10 milligrams.
Okay, very good. So what are the contraindications to giving, what are the precautions of giving the IV adenosine? Any patient cannot receive adenosine or ATP?
If the patient has severe asthma, then maybe it can trigger some bronchospasms.
Yes. So always, so when you do vagal maneuver such as carotid massage, make sure there's no carotid buoy or history of carotid stenosis. So when you gave the patient ATP, make sure the patient had no history of asthma before. So if you have asthma, you can always give another drugs. What are the other drugs you can use?
Maybe IV amiodarone.
Amiodarone is not useful in SVT. It may be useful in patients with atrial fibrillation, or it may be useful in patients with ventricular tachycardia, but it's certainly not useful in patients with SVT. Although amiodarone has some beta blocking effects that may lower the heart rate, but usually we don't give amiodarone in patients with SVT.
So maybe we can try some calcium channel blockers.
Yes. Excellent. So this patient has supraventricular tachycardia. If unstable, I would do synchronized DC cardioversion, start with 50 and then escalate to 100 if fail. And if the patient is stable, then we try vagal maneuver, such as carotid. And what we are using nowadays is ATP. ATP come with 20 milligram 1 ampoule. So you could either give 1 cc or 22 cc, and then followed by some saline flush. The textbook usually mentions adenosine, and adenosine is usually available in the United States. And what we are using is ATP from Shanghai. So we are using ATP, and the dose is 10 or 20. So we can give IV verapamil, but make sure this patient is not in shock. If the patient has hypotension, you cannot give IV verapamil because it may cause hypotension as well. So for chronic therapy, you can maintain the patient on isoprene or consider electrophysiological study and radiofrequency ablation. Okay, so I will go to the last case. Yes. 有冇 volunteer 呢個 last case and has been asked in exam about 5 years ago. Any volunteer?
I can try.
Oh, thank you very much. So this is a 85 years old gentleman, hypertension, diabetes, hyperlipidemia, history of stroke, admitted for chest pain for 1 day with elevated troponin. ECG show some ST depression over lateral leaks. So this patient is admitted for NSTEMI and developed sudden onset palpitation, chest pain. So this is the ECG. What is your diagnosis?
So I can see that this is the ECG of the patient. The patient is in tachycardia, but the most striking feature would be a widened QRS complex. And there is also no discernible P waves.
So what is this? What is this? Can you see my pointer?
Oh,
and this one.
so are those the P waves?
Yes, I think it may be P wave here, and maybe a P wave here.
Right.
So why is there some narrow bits and some in between this narrow bits and wide bits that you have some intermediate one between the two? So what are those called?
So there are some ectopic beats or escape beats, or
so what is your diagnosis? This one is difficult, I must say. It's all right that you
are
cannot.
those like fusion beats?
Yes, fusion beats. So you would say this ECG is from Two Moon because I worked in Two Moon for 7 years before I actually start working in Prince of Wales Hospital and then go to Two Moon Hospital for cardiology training and then come back to Prince of Wales Hospital. So I've been staying in Two Moon Hospital for 7 years. And this is one ECG that I encounter in CCU. So you can see there is evidence of course, this is a Y complex tachycardia. It's actually somewhat regular, at least in the first part. And then you have some evidence of AV dissociation, evidence by independent P wave seen. And also, this is capture bit. You see this one is relatively narrow. This is a P wave followed by the normal QRS. And then this intermediate one are the fusion bits. So this actually is having quite a relatively slow VT, and perhaps his sinus rate is also fast. So 好多撞埋一齊咁樣. So you have independent P wave seen, you have fusion beats, you have capture beats. It's regular Y complex tachycardia mostly. So this is a case of
Ventricular tachycardia.
Yes.
Or
and yes, especially in case of NSTEMI. So this is a case of ventricular tachycardia. So how would you manage this patient?
so again, I'd like to assess the hemodynamic status of the patient.
Yes, say the blood pressure is now 70/40. Patient is still talking to you, but in distress.
So I would like to consider if the patient is hemodynamically unstable, then synchronized cardioversion.
Yes. And how many joules you will start with?
Around I'm not sure, about 100 to 150 joules.
Yes, I will usually start with 150. You can start with 100 and then go up to 150. And after reverting to sinus, what will you do? The patient now becomes stabilized blood pressure 120/80, but still ongoing chest pain. What will you do?
So if the patient has ongoing chest pain, so I'd like to relieve the patient's chest pain by considering maybe would IV morphine be okay or as a type of analgesic for the patient?
Yes, this is symptomatic treatment, but what are the definitive treatment? So what I want to hear is, because this is caused by ischemia, right? So of course, treating the VT, you correctly point out that you will do immediate cardioversion, and then you can maintain the patient on IV intravenous amiodarone. But the underlying cause is due to myocardial ischemia with ongoing testing.
Can undergo some reperfusion therapy.
Yeah, you need to arrange urgent coronary angiogram and plus or minus PCI. Of course, you have pharmacological treatment in ACS patient, such as antiplatelet treatment, antithrombotic treatment, anti-anginal treatment, and statin, etc. But more importantly, this patient required an urgent revascularization because of ongoing ischemia and also ventricular tachycardia. This is very high risk ACS, so you need to go in as soon as possible. So perhaps any questions? I would like to end here. 英文得嘅喎，真係中文都得。
Any questions？ 有冇問題？
考試我仲有未 cover 就喺 Cardiology I 嗰度咧，就金醫生會講嘅。考試咧，即係最 common 考咧就係STEMI 啦，考你 SVT 啦，考個 heart block 啦，考個 PE 啦，即係 sinus tach 啊 S1Q3T3 啦。考個 VT 啦 ，with 一個AV dissociation 啦 ，fusion beat capture beat 啦。咁咧就頭先 show 嘅 ECG 咧，其實都係 taken from the examination，but with real case，啲 those are the real case seen by me。So 即係我睇過、見咗佢考過呢啲咧，我全部攞晒出嚟講俾大家聽，應該點樣答問題，點樣考嘅。咁咧就at the same time 都係好有用，因為即係你將來見啲 real cases 都係咁樣嘅。咁你要知道點樣 manage。咁要即係平時都要有研究下諗下咁樣咯。咁咧就有冇咩問題咧？因為大家而家冇得上 Ward 啦，就算上 Ward 都未必咁好彩見到呢堆 case。即係呢堆 case 我都做咗10幾年，仲有好多有成70-80個 case 可以講。咁但係我覺得 select 咗一啲會考試會考嘅你哋最 concern 嘅嘢，即係嚟到教大家啦。咁同埋其實 subsequent 你仲有好多堂咧係唔同科嘅，即係包括即係 ID 啊、Neuro 啊、Jury 啊咁樣，好辛苦先揾到啲同事教大家嘅。希望即係大家即係都盡量花啲時間去聽啦，因為其實都係我哋好多年嘅經驗教俾大家。其實你哋都冇上 Ward 啦，何來有 clinical sense 係咪先？即係難怪人哋啲 senior 出嚟講，同我講話，喂，而家啲畢業生就唔係好有 clinical sense 喎咁樣。咁因為大家都冇上 Ward，點會有 clinical sense？ 咁希望彌補翻大家呢一個嘅即係缺口啦。即係希望大家學多啲，諗多啲。譬如如果遇到呢個病人會點做啊咁樣。咁將來大家真係見到個病人嘅時候，你都起碼識得即係要做啲乜咁樣咯。係咯。
唔好意思啊，徐醫生，我想我有一個問題想問。
好啊。
係其實就係想問嗰個grade score 咧，其實係即係咩情況之下係真係會咁樣去計分
？ACS patient 咯，但係咧其實我 show 翻俾你睇啊。係咪呢個？睇唔睇到啊？好，呢度。其實咧我諗啊，摩係一個嗱，當然如果你個醫院係可以清晒啲 ACS 嘅，所有 ACS 都其實咧應該咁講，幾時需要做 PCI 咧？其實 PCI 咧就有 survival benefit 咧，就只係 prove 咗係呢個end STEMI 同埋 high risk 嘅即係 STEMI 同埋 high risk 嘅 end STEMI 啦，同埋 high risk ACS 啦或者咁咧就。你點樣知佢係 high risk 定 low risk 咧？就有人 develop 咗啲 scoring system 啦 ，grade score 就係其中一種啦。但係我自己覺得咧，就即係有人 validate 過話啊，即係呢一樣都分到究竟佢係 high risk 定 low risk。但係佢又其實有啲缺陷嘅。其實有時有啲好 specific pattern， 譬如佢俾個例，佢係 Wellens syndrome。你諗下，佢有冇 significant SD depression 啊？佢冇喎。佢可以個後生嘅喎，佢亦都可以冇 heart failure 冇 MI 過。亦都可以 BP 係入嚟 normal，heart rate normal，creatinine normal，biomarker normal， 冇做 PCI， 但係佢係咪 high risk 咧？佢係喎，係咪啊？咁你好多嘢其實個 score 未必反映得到嘅。咁當然你有人做 study 做咗個咩 score， 可能攞咗啲一紮 end STEMI 嘅 patient， 即係整咗個 score 去 predict 究竟 high risk 定 low risk。咁咧就所以咧就如果你個 resources 咧係容許嘅話咧，其實我哋就算我哋醫院咁樣啦，譬如我覺得個病人係 ACS 咧，我哋就會全部做晒 PCI 先出院嘅。咁呢個就其實你計唔計都唔係太大分別啦。咁但係如果我 一個間醫院，譬如個 cat lab 好爆嘅，都清唔晒啲 case 嘅。咁我冇理由留個 patient 咁耐㗎。咁我哋有啲方法 objective 啲去 assess 究竟個病人係 high risk 定 low risk。咁我 high risk 嘅就盡量 inpatient 做晒 ，low risk 嗰啲我就俾佢出院再遲啲翻嚟做。咁呢個係一個 resources 咁樣 limitation 先至咁做嘅啫。咁當然你有啲 pattern 你要記得啦，即係例如 Wellens syndrome 就唔 fit into 呢度喎，但係都係 high risk 喎。例如好勁嘅 SD depression， 你叫咗 diffuse multiple leaks， 好 severe SD depression， 呢都係 high risk， 未必喺個 Square score 度可以反映到佢係 high risk 㗎。咁所以咧就我會咁樣睇咯，即係其實如果某啲醫院咧佢唔係做晒啲 ACS 嗰啲咧，咁就可能用個 Grade score 去分究竟邊啲 high risk low risk， 咁啊有啲可能要冇辦法啦，要 discharge 咁樣咯。咁咧就唯獨是即係 PCI 咧喺high risk 嘅 ACS 咧係有 survival benefit 嘅。咁咧就喺譬如 stable angina patient 咧 ，PCI 主要都係冇一個 survival benefit proven 嘅，咁啊只係 relieve 個 symptom 嘅啫。咁所以咧就 ACS 咧，如果你所有 ACS 咧，咁有啲醫院例如 QE 啦，例如我知道嗱打數或者北區有時都會計個 Grade score， 即係去當係一個即係 objective 少少嘅 assessment， 分佢究竟係 high risk 定 low risk 咁樣咯。因為其實 guideline 都講嘅，其實如果你 high risk 咧，就係 early invasive strategy， 就係 within 即係24至48個鐘要做 PCI 嘛。咁如果你 low risk 咧，即係譬如你講真，你 Grade score 細過140，又冇 ST changes，CHOP T normal， 咁你係可以做一啲 further investigation， 例如 CT 啊，例如stress test， 例如 treadmill 啊、MIBI 啊或者 MRI 咁樣咯。咁但係咧，其實我話俾你聽咧，大部分 case 咧最恐怖嘅咧就好多時咧就係嗰啲 unstable angina 嗰啲 case， 即係譬如如果個病人話俾你聽，我最近行路心口危。行幾步都痛，唞下又好啲，咁咧就呢個禮拜開始嘅。咁其實你諗下，如果你計 Grade score 呢度會唔會係好高分啊？如果你 CHOP T normal，ECG normal，M3 normal，heart rate normal， 冇 MI 過，咁呢度反映唔到嘅喎。咁但係個 patient 一出院咧，佢就可能 MI 入翻嚟。我試過見過一年都有幾個咧，即係你知 A&E 有個 chest pain protocol 㗎嘛。咁咧就佢可能chest pain protocol 做兩張 ECG， 抽兩個 CHOP T negative 就踢你出院 refer medical 就3年之後睇咗 medical 之後再排個 treatment 1年之後 treatment 完1年之後再等1年先做 PCI， 咁你其實 turnaround time 都幾年㗎喎。咁你呢啲 case 其實話到俾你聽，其實都係 unstable angina by definition 都係 ACS 啦。咁但係你呢啲 score 反映唔到佢有幾嚴重咯。咁所以我自己個人認為咧 clinical application 咧其實就唔多嘅。咁但係有啲純粹係一個叫做resources limitation 嘅情況底下，有啲人會用有啲醫院咧係會用呢個方法嘗試去 risk stratify patient 咯。但係喺我嘅眼中咧，所有 ACS 都係 high risk 咯。即係如果你真係覺得佢係 NSTEMI 係unstable angina 咧，直接高 cardiac 啦，即係或者叫佢做 pilot CTCA 咯，唔好等唔到嘅。有幾個一年咧，總有幾個病人咧，即係咁樣入翻嚟，或者喺街度死咗，或者入翻嚟都救唔翻。所以 history 先係最緊要咯。即係我成日覺得咧，即係 even 你最近個 guideline 2021年咧，佢哋有一個 joint guideline 出咧，佢都係話俾你聽 ，history is the most important in assessing chest pain patient with chest pain 。所以其實 history taking 係最緊要。咁當然啦，如果你好 high risk， 譬如呢個 unstable hemodynamic shock、arrhythmia 即係 VT 啦 ，mechanical complication， 咁呢啲梗係要即做啦。咁咧就 heart failure 或者好似頭先我講 ST elevation 嘅 AVR 呢啲嘅 high risk， 新嘅 guideline 就加咗呢兩句。嗱我唔係話好同意，不過 anyway 啦，頭嗰5個咧就係要即刻做，因為會死嘅。咁 high risk 就譬如你 NSTEMI CHOP T 高啦，有 UCG change 啦。或者 Grade score 大過140咯，咁你 resuscitate cardiac arrest without ST elevation 啦，或者 shock 咧，佢都係 high risk 咁樣咯。冇呢啲 features 咧，就叫 low risk 咁樣咯。咁 low risk 咧就可以做一啲 assessment， 但係我覺得咧，其實history 先緊要咯。如果佢 history 都有一個似人 unstable angina咧，盡快幫佢做啦，唔好出院，一出院咧等好耐。人哋講嗰啲咧。low risk 咧，佢做 imaging 咧係第二日嘅，可能係第二日 guideline 或第二日做 CT pick up 到，跟住就第3日就做 PCI 咁樣嗰啲咯。我哋嗰啲 system 係咩咧？你俾佢出院等2年先排到個 CT， 咁你已經冇咯。人哋嗰啲唔係喎，人哋嗰啲係第二日或者即日做 stress echo， 你哋做唔做到啊？做唔到。咁所以我覺得所有 ACS 咧，你唔好用個 grade score 去分啦。如果真係覺得 unstable angina 咧，就 go for invasive strategy 因為我哋 resources limitation 嘅。係。好，咁OK 啦，多謝大家嚇。
係啦，咁再次多謝Dr. Choi 啦，即係喺繁忙之中咧都揾到咁多 cases， 即係我都係好希望我係做 medical student 嗰時候可以聽到你咁樣教書法，咁真係非常之有用啊！嗰啲我咁再次係多謝大家啦，咁即係將傳統嘅啦，即係呢啲好重要好多 experience 嘅 acute medicine series， 咁陸續有嚟一傳同今日Dr. Choi 都講過。Anyway, thank you very much, Dr. Choi, and thank you all 嗰啲答案啦。學生都好好啦，即係有一個MO 都嘅 case 咧，竟然係可以咁做。OK, thank you very much。咁
thank you very much。好，拜拜各位，多謝晒。